All right, good morning. I am subbing in for my colleague, Jay Bott, as the interim chair of the Quality and Patient Safety Committee. So I'd like to call the meeting of the Quality and Patient Safety Committee to order. Will the secretary please call the roll?
Director Kim? Director Sorrell? Is absent. Director Stain? Here. Director Webster Cross?
Present.
Chair Bott is absent. And Acting Chair Garza?
Present.
And remotely attending is non-director member Patricia Merriweather.
Present.
And for the record, other directors present, Director Harrington.
Present.
You have a quorum.
Thank you, Madam Secretary. I'll share that the next regular meeting of the committee is scheduled to be held on Friday, October 24th at 9 a.m. I'd like to entertain a motion to allow directors, Director Webster Cross to remotely participate in this meeting as a voting member. Thank you. Is there a second? Thank you. Is there any discussion on the motion? Thank you. All in favor, say aye. Aye. Thank you, and all opposed. Okay, the ayes have it, and the motion will carry. The first item on today's agenda is public testimony. As a reminder, written testimony will not be read into the record, but will be included in the official record of this meeting and posted to the website. Madam Secretary, do we have any speakers who have registered to provide in-person, virtual, oral testimony or submitted testimony?
We didn't receive any registrations for testimony nor any written testimony.
Thank you, Madam Secretary. The next item on today's agenda are proposed Stroger Hospital Department Division Chair appointments, reappointments, which will be reviewed by Dr. Lauren Smith, Chief Medical Officer.
Good morning, directors.
Good morning.
Lauren Smith, Chief Medical Officer. I have 3 reappointments this morning for you. Dr. Ina Mohapatra, Chair of the Division of General Internal Medicine under the Medicine Department. Dr. Mohapatra completed her internal medicine residency at Cook County Hospital in 2005. She first joined CCH in 2008 and was first appointed division chair in 2019. And next is Dr. Mark Misick, chair of the Division of Research for Emergency Medicine. Dr. Misick completed his residency training at Boston Medical Center. He completed a fellowship in medical toxicology here at Cook County with the Toxicon Consortium. He joined CCH in 2009 and was initially appointed division chair in 2019. And last, Dr. Joseph Weber, chair of the Division of Pre-Hospital Medicine under the Department of Emergency Medicine. He did his emergency medicine residency here at Cook County Hospital and first joined CCH 2003 and was initially appointed division chair in 2014.
Thank you. I'd like to entertain a motion to approve item 3A, the 3 proposed Stroger Hospital Division Chair reappointments. Thank you. We have a second. The motion has been made and seconded. Is there any discussion on the motion? Okay, all in favor, say aye. Aye. Thank you. All those opposed? And once again, the ayes have it, and that motion will carry. Let's see, we will now go to Dr. Tom Patrianakos, President of Stroger Hospital Executive Medical Staff, followed by Dr. Paul Allegretti, who is the President of the Provident Hospital Medical Executive Committee. And they will now provide any reports and will present their medical staff action items for the committee's consideration and approval.
Good morning. My name is Neha Sheng. I'm the Vice President of the Executive Medical Staff. Dr. Patronakis could not make it today, so thank you for allowing me to present. I do not have any notable findings from our credentialing committee, and the executive medical staff recommends proceeding with their recommendation. I'm also presenting the Hospital Quality and Safety and Patient Safety Committee findings from July, in which there are a couple of highlights, all good things. So they did a specific focus on the environmental services in the hospital, and more than 830 inspections were carried out, and their goals were essentially exceeded for PPE compliance and education and enforcement of PPE protocols, reflecting a strong culture of oversight and some dedication from our frontline teams in environmental services. There was also a specific review from the laboratory, who is exceeding their goals in terms of on-time morning blood draws, reaching their goal of 80 to 85% of on-time blood draws in the morning. And blood culture contamination rates are significantly below the goal, so 1.73% below the goal of 3%, which is great. If there are any questions, I can answer them now.
This was an external review,
This was internal,
internal. So this is the committee that did the review?
correct.
Okay, thank you.
Any other questions? Okay, I'd like to entertain a motion to approve item 3B, the Stroger Hospital and Providence Hospital medical appointment, medical staff appointments, reappointments, and changes. Is there a motion?
So moved.
Thank you. Thank you. Motion has been made and seconded. Is there any discussion on the motion? Okay, all in favor, say aye.
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 All opposed? Thank you, sorry. All opposed? All right. The ayes have it. Thank you. And we'll turn it over to Dr. Paul already. I got ahead of myself.
We did a little bit, but it's
Yeah.
fine. He can provide whatever report
Yeah.
at this point.
Do you want me to go back and do the, okay. Sorry about that. Go ahead.
That's okay, thank you. Paul Allegretti from Provident, and I am here to present the credentials report. The Credentials Committee met for Provident on August 26th and approved the document that you received, and this was also approved by the Medical Executive Committee on September 5th. And I'm here for any questions or comments and respectfully ask your approval for appointments and reappointments.
Any questions or comments? Okay, thank you. All right, the next item is the August 8th committee meeting minutes. These were approved at the August board meeting, but are being presented for any further edits or corrections if needed. Are any corrections needed to be made to these minutes, please? Item 3C8, 825 QPS Committee Meeting Minutes. Okay, hearing none, then I would ask for, I would entertain a motion to accept item 3C, the August 8th, 2025 meeting minutes of the Quality and Safety, Quality and Patient Safety Committee.
Second.
Thank you. The motion has been made and seconded. Is there any discussion on the motion? Hearing none, all in favor?
Aye.
All opposed? All right, the ayes have it. The motion carries there. The next item to review is the review of the OpEx dashboard goals and tactics by Donica Austin Cathy and Dr. Arnold Turner and Dr. Sharon Irons.
Good morning, directors.
Good morning.
Donica Austin Cathy, Chief Hospital Executive for Stroger. So taking a look at the Stroger OpEx Committee dashboard, overall, 4 of the 9 measures are meeting and exceeding our stretch goal. 2 of the 9 measures are meeting and exceeding the goal. 1 is currently better than our baseline, and 2 of our measures currently have not met the goal yet. Next slide, please. Next slide. Next slide. Okay, thank you. Taking a look at our dashboard, our first domain is our patient experience, provider communication, and our nursing communication. Our rolling score for provider communication improved to 85.82, consistently meeting our target. And currently, the monthly scores peak at 90.3, showing a sustained high performance in our provider communication. Also, looking at our nursing communication, the rolling score improved steadily to the 76.3 by July of 2025, and our monthly score for several months hit 80 plus, supporting the improvement that we're seeing in nursing communication. So both scores, we're incredibly proud of the work that's being done by our nurses and our nurse leaders and our physician leaders around the training, their focus on compassionate, connected care, the I-rounds that are going on, and the hourly rounding that's happening. Moving to our clinical outcomes, looking at our mortality index, that's the rolling 12 months. Our rolling index remains at 0.91, above the target, which is 0.80. The monthly fluctuates ranging from 0.5 to 1.19, and so we're seeing a little bit of inconsistency there. We do have a mortality committee that started in January of 2025. This is a new group, and they are really focused on, the physicians are currently screening each of the cases and looking at the most impactful cases, and they're pairing with our nurse executives as well. So physicians as well as our nurses are working collaboratively. Also, they're collaborating with our Associate Chair of Medicine, Dr. Pierco, so that they once the physicians review, they send those cases for review by the Medical Oversight Committee and the Department of Medicine, and obviously they're continuing to track any outliers. For a patient safety indicator, the rolling index improved from 1.12 in August to 0.96, which is close to the target of 0.9. They have seen also some variance, but there's a lot of work being done on our patient PSI 90. Also, in our sepsis, rolling compliance dropped sharply from 70.3 in July of 2024 through 40 to 44.25 in June of 2025. The monthly rates are highly variable, and currently their sepsis bundle for July is currently under review, with the several fallouts being reviewed by the sepsis committee. Also, they're working with the external company, our partner, CCH, on that as well. Looking at our readmissions, the 2 measures, post-hospital follow-up days, our rolling measure improved to 18.1 by August of 2025, which exceeded our stretch target of 20. And our monthly results show many of the days are well below the target. Also, our rolling rate improved for COPD rate, improved to 12.8 in June of 2025, consistently been better than our target of 14. Also, the monthly variation has been high. We've seen in the last 3 months, April, May, and June, there were a few high readmission months, And due to this, there was a low volume, and so we know that the low volume can cause variation in the data. But they're going to partner, the team is partnering with our business intelligence leaders to provide the work group, the individual encounters for them to do a deep dive in a root cause of that variation. And moving into the last one, the domain of throughput, our geometric length of stay, the rolling decreased from 1.91 in August of 2024 through 1.43 in July of 2025. So we are knocking that out the park with better than our stretch goal of 1.30. So a lot of really great work on our geometric length of stay. The ED length of stay for ED discharge patients, our rolling decreased to 286 from July of 2025, surpassing our stretch goal of 288 minutes. Our monthly results, we continue to monitor those, and there is a focus on a monthly basis looking at our ED length of stay for our ED discharge patients. And let me pause to see if there's any questions.
Can I just ask a little bit about the sepsis? And I think you said you had a task force working on that, and are they finding any particular concerns that are getting addressed, or how's that work going?
So that's currently being led it's co-chaired by Dr. Radigan. Currently, they've revamped the group, and they're trying to look at, so at first they were looking at each and every case. And so right now they're trying to, they're using kind of a best practice so that they take the most impactful cases so that they can make the most impactful change, right? So that work has started. And then the fallouts, they are sending those to the Department of Medicine for a deeper review with our Associate Chair of Medicine. It's a new process that has just started in the last couple of months. So I'll be excited to report out, and hopefully you'll see that in the data as the work continues to be done.
Director, if I could add a comment. So we brought the team here last month to give a very in-depth review of their processes, structures, and what has led to some of the, sudden changes in the numbers from, being at really above the baseline to what looks like a bad performance run numbers. However, the change is not because of any changes with our clinical processes or the quality of care, but it has to do more with the review process, as Danica was alluding to. So ever since we engaged with this external group, a vendor who is helping us perform concurrent and retrospective review of these cases, we have identified that maybe there is an opportunity to tighten up our internal review processes. That's why the numbers look a little bad. However, in terms of improvement effort that's happening, as Danica mentioned, there is a work group working on improving sepsis bundle complaints. Our sepsis rates are actually pretty good. It's basically above the national, like 90% percentile of, what you see outside in the national benchmark. However, in terms of sepsis compliance, the team is focusing primarily in the ED to make sure that, is a lactate or, the whole bundle is taken care of in a timely manner. So multiple approaches, being utilized concurrently to address this issue. But one thing we know from our internal and external reviews is that it's not a quality of care issue, but it's more of a documentation issue.
Oh, very helpful. Thank you. Appreciate it.
Also, I do want to add also that they have a sepsis bundle order that they are working on, and so that's been approved by our Chief Medical Officer as well.
I think we're good to proceed. Thank you.
Thank you.
Thank you.
Good morning, everybody. I'm Mike Moonen. I'm the chief nurse at Providence Hospital. Today I'm presenting for Dr. Turner.
Morning.
Good morning.
Okay, so for Provident, our OpEx committee dashboard, you can see 4 out of our 6 had met or exceeded goal. The upper left-hand corner is one of the areas that we are still struggling, and that is quarterly surveys returned. This has been running improved, however, still mostly between 15 and 27, which is below target. It's a raw N number that is our target for responses. It does remain a challenge. One of the tactics that we did recently was demographic rounding. So we are rounding on 10 patients a week, feeling that, you know, in the rush of patients coming in through the emergency department, perhaps some of the name and address, et cetera, was not captured appropriately. But fortunately, we found that we're averaging over 95% accuracy with that. So that does not appear to be the issue for the struggle. So we are keeping after that with our eye rounding and really trying to encourage patients or families to, you know, encourage patients to return the surveys. The next item is our Provident Increased Nursing Communication Top Box. And you can see 3 of the last 4 months were above target at stretch goal. Some of the things that we are doing to achieve this is our eye rounds. Weekly, we are doing 40 rounds per week. Our rolling scores improved from 71.8 in October of 24 to 79.3 in August of 25. Monthly scores have fluctuated between 50 and 100%. I think that is largely due to the smaller sample size. You see more label, you know, scores from month to month, but many of the months are exceeding the stretch target. So upward trend, something we take extremely seriously at Provident, and we are going to stay after that. Our next item is our, left without being seen. I'm trying to see up there on the board. So
to the next slide?
I can go off this one. Okay. So the next item is our sepsis score. Sorry, our rolling improved rate was 46.7 in August 24 to 58.9 in July of 25. The monthly improvement again tends to be a bit volatile, but again trending upward. A little bit of inconsistencies, and we are focusing on our process standardization. So like Donica said, one of the issues that we were having at Provident is just it is a fairly complex process, and it can be kind of restarted with a sepsis alert after a patient may have initially been ruled out. So we developed the sepsis green sheet, which is a job aid, excuse me, with check boxes so that the nurses and providers can stay on course with moving through the sepsis bundle process. Okay, next on the list is falls. So our rolling rate decreased from 30 in September of 24 to 14 in August of 25, meeting our stretch target. Monthly falls dropped about 2 per month consistently, and obviously a significant improvement overall with falls well below target and meeting national patient safety goals. So some of the things we did is auditing our must-haves. So there are, you know, standard best practices around SOX and appropriate assessments, et cetera, that we are auditing for compliance. But additionally, I want to raise up my director who started a fall room program. So we have a fairly large unit, and we made sure that fall patients are placed in rooms that are very proximal to the nurses' station. So we have a better response and better awareness of those patients. Okay, next item is our left without being seen. Rolling rate fell from 140 in September of 24 to 105 in August of 25. Better than target and nearing stretch. Monthly data shows a sharp improvement with several months below target. I want to raise up Dr. Allegretti and his team. One of the major initiatives we did was securing a provider in triage. This enables the patients to, immediately be seen by a provider and initiate an action plan and know what that action plan is going to be, and have a general sense that things are moving forward for them, and generally will prompt them to stick around. And lastly, our ED decision to admit to depart. Rolling rate dropped from 6.6 to, these are 6.6 to 1.1%, achieving stretch target. Sorry, I got these flipped around. I was wondering, these are left without being seen. Monthly left without being seen has been consistently below. And again, just a summary of outstanding improvement. So with the ED admit to depart, that is a byproduct of the left without being seen. So if we initiate that provider care, again, it tends to expedite patients through the whole ED care continuum. We also did amend our throughput committee, which I think was a key initiative this year. Prior, it was kind of a informational committee where the senior nursing leaders were just speaking to the issues. And what we did in amending that was making each part of that process, be it EVS or transport or registration, partnered with them to get all of those folks to have their own goals as sub-processes to the overall process. And every month they report on those goals, whether or not they're hitting targets. So overall, I think between the provider and triage and that initiative, it is driving those improvements. That is all I have. Any questions?
Any questions? Thank you, Michael. Doesn't appear to be.
Thank
Nice
you.
work as well.
Thank you.
I appreciate it. And then we'll do the ACHN site review by Dr. Sharon Jones. I'm sorry, Sharon Irons.
Thank you. Good morning, directors.
Good morning.
Yes, my name is Sharon Irons. I'm the Medical Director of Ambulatory Services, and I'll be presenting this with Claudia Birchinell, our Primary Care Executive Director, and we are both presenting for Craig Williams. We'll go ahead and get started with the Press-Ganey data. Good morning, directors. My name is Claudia Birchinell, Executive Director of Ambulatory Primary Care. At ACHN, we have 7 questions in our patient experience survey. However, we have selected 3 as a top priority for ACHN FY25. The reason is because questions have a higher correlation to patients to recommend us. The 3 are staff working well together. Here, the rolling 12-month score has shown gradual improvement. We started back September at 64.3, today at 66.7 as of August. However, we have met and exceeded on some months the monthly score. However, we have not been able to meet target. Back in April, we implemented a task force that has focused in 2 specific things. 1 is increasing the measure for this score, and 2, improving the response rate. So as of today, after this team has been implemented, we identified that 12% of the response rate was due to delivery method. They were not getting through. So we went down from 12% to 6% by improving the collection of information of patient phone numbers and emails. We're staff working well together. What we did is we adopted several things that other clinics were doing well into those clinics that had low scores. And we also had requested all leaders at every single clinic to create and provide a plan that is tailored to their clinic and how to improve this measure. Now we're focusing, we are creating a town hall meeting that is called Thriving Together, where we want to hear the voice of our staff, because this is key to be able to create teamwork across the ambulatory team. For the second measure, provider explained problem condition, the rolling 12-month score has improved from 65.6 to 67%. Several months reached or exceeded the monthly goal. Overall, we see an upward trend, outperforming target and approaching stretch goal. This is one of the strongest experience domain, which is the third one. And then in the second, provider addressing concerns, the rolling 12-month scores has improved as well. A overall improvement with rolling scores is steadily rising towards target. Now I'm going to pass to Dr. Irons to discuss the HEDIS measures.
Fantastic. We're going to go ahead and pivot to these health outcomes. The first one that I'll be reviewing here is breast screening, which we're doing in 40 to 75-year-old women, Q2 years. Our target for that is 55%. We started off with a baseline last fall of 53.3%. We set a stretch goal of 58.4%. So we are doing very well, and as you can see, we've been steadily getting better and better. Our current is at 62.5% for our rolling 12 months, and we are, with that, exceeding our stretch target even. And there's various reasons for that. We do have our care coordination teams now doing outreach to patients. We initially started this as the birthday program that was put in place by Commissioner Lowry and President Preckwinkle, and we kind of pivoted off of that and getting patients in. So we did see an increase in rate. Additional mammogram access we now have at our mammography centers, in particular at the Stroger campus. We are now offering Saturdays and evenings to provide additional access for women who obviously can't make it during the week. We also have trained our staff, medical assistants and clerks, to actually schedule the mammograms directly instead of waiting for it to be sent to them in the mail or get an auto text about it. So when they're leaving the clinic upon discharge, they're walking out with mammogram appointments in most cases, and that actually increases the show rate. So those are reasons for that. Our next metric is hypertension, blood pressure control. We've been doing really well with that as well. Blood pressure less than 140 over 90 is the HEDIS metric. Our baseline was 55% at the end of last year. We set a target to increase by 2%, 57%, and set a stretch goal of 61%. Our rolling 12 months is at 59.9%, which is nearly 60%. So we are exceeding the goal, haven't yet hit the stretch goal, but feel very good about it. We have several reasons why this is happening. I think that just for context, way back in when the pandemic started, 2020, our control rate was around 32% in primary care system-wide. So we've come quite a long way. We've been partnering with the American Medical and American Heart Associations, trained our medical assistants how to measure accurately the blood pressure. We have also partnered with patients, ensuring that they have blood pressure monitors at home. That helps with self-management. And we also are working with providers across the system to ensure that when a blood pressure is out of control, they actually adjust medications or do some type of treatment regimen and get the patient back in fairly quickly within 2 to 4 weeks as opposed to 3 to 4 months. So we have had some good progress with that as well. And then finally, last but not least, is empanelment, primary care empanelment across our primary care centers. We started off with 116,000 roughly patients being empaneled to us, and our goal was to increase that to essentially 119,000. over the last rolling 12 months. We've had a little up and down, but we are steadily going upward, and now we have about 118,000 patients in panel to us at this point. So we are actually improving and going toward our goal. So any questions?
I do have a question. First, I want to say that I appreciate that you've expanded access for the screenings, the mammogram screenings on Saturdays and evenings. I'm just curious. Wait till Kenny G.
Nice music.
I'm just curious about what the utilization has been since you've expanded the access, like what the response has been.
Yeah, when you say utilization, you mean utilization of the appointment slots?
Yes.
I will need to get back with you on that,
Yeah.
but it has been higher than what it's been in the past, and that's namely due to outreach. We actually have our care coordination team now outreaching to patients. They're running lists from our healthy registries, and when they see that someone hasn't been in within the 2 years, they're getting them in, getting appointments, but I can get back to you on that specific data. Thank you.
Yeah, I appreciate that. Yes, Director.
Go ahead.
Just a question on the blood pressure monitoring. How does, so it sounded like, and it's awesome that it's going much more quickly and adjusting meds when something's not working. How does that information get back to the provider that things aren't going well?
Yes, so we actually have care management visits with our RNs in the clinics now. So they will either have the patient come back in for a blood pressure check, bring their own blood pressure monitor, and they communicate that information, what the blood pressure is, to the provider in real time. And then the provider usually has a 24 to 48-hour turnaround where they actually increase the medication, reach out to the patient or nurse to make whatever intervention or change that is needed. As we continue to roll out, Cook County Health is a part of Live Healthy Chicago, which is a group, I'm on that steering committee, where we are looking at West Side citizens as well as South Side. And part of what we'll be doing is what is called remote patient monitoring, so that we will be getting patients so that the information can actually get into the electronic health record. So it'll be at a pilot phase, but as we expand, we want to do this, broadly throughout the system.
Yeah, I was wondering whether we have that capability for the remote monitoring.
Very,
So,
very soon. And we have done it. We have piloted it, but we really want to get serious about it now and roll it out.
Thanks.
Yeah, my question is relative to the upper row of services. What I'm trying to understand, and when I look at it, and I look at the chart across the board, that there's significant improvement, that there's a decline, then it goes up, and it's over, but that's been consistent. So I'm wondering what happens. I mean, do you do an intervention, and then things get better, and then they go back to the norm, or are there new things coming up? That's what I'm trying to see.
I'm sorry, is that in regard to the patient experience data at the top?
Row, yeah, it's pretty consistent in terms of things improving dramatically in some cases, and then dropping below the target. That's what I'm trying to understand. What happens in the periods between?
So for the rolling 12 month, it's being consistent, the growth, the improvement. However, we have noticed for those monthly, it's because of any specific initiative that has been taking place, immediately triggers that. And that's what we're trying to create, that consistency, not only for one specific month.
So the things that happen that you have to go back and revisit something new.
That is correct. We go in and evaluate again, like how do we got to those numbers?
And so that's what you look at as soon as there's a drop, I assume.
That is correct.
Right.
Any other questions? Thank you, Dr. Irons. Next.
Thank you.
Thank you.
Thank you.
Okay, the committee will not be going into closed session today. Well, actually, before I close out the meeting, I do want to recognize an achievement that was awarded to our Cook County County Care program, where we received a 4-star rating by the National Committee for Quality Assurance, and that happens to be the highest, makes us the highest ranking Medicaid plan in the state of Illinois. And I want to recognize Dr. Makaitis and Aaron Kaliner is not here, but also that, you know, this achievement is not only specific to county care. To the extent that our county care patients seek and receive services from the Cook County Health System, that contributes to those accomplishments as well, which is why I've been very adamant that I think that there should be more, and I know there is, I saw the press release on this, but we just have to continue to raise awareness around the quality care that gets presented in this meeting, but that happens every day in the system, because these kinds of accomplishments I don't think are specific to just one area. I think it's a broader system approach, and I know we're strengthening that approach continually so that we're becoming more integrated and we see more of this type of accomplishment on behalf of patients. So I just wanted to share that, but congratulations, really good work. Says a lot when you're the only 4-star health plan in the state of Illinois, especially at a time when the state is seeking new responses to the RFP that was put out a few days ago. So I wish the county and county care luck in pursuing that. With that, so as I was saying, we're not going into closed session today. So if there are no other questions or matters, yes, Joe?
Just a comment, an observation.
Sure.
Yeah, I think it's a credit to the people that do the work. So we need to stand up to the people that actually do the work, that make these numbers possible. And without them, these numbers wouldn't be possible because it gets lost. It's the system that's getting the credit, but it's the people that do the work that deserve the credit. So when you go back, let the people who do the work know that they were talked about this morning.
That's right. I was going to jump in and say, well, first and foremost, thank you both for your comments and congratulating the team. But yeah, this is a testament, I would say, to Aaron's leadership and the team that really worked to coordinate and make sure that our patients or our members received, very high quality care. And it's also, I think, a sign of the partnership with the provider side, right? Where our members go to get their care, and that coordination and partnership with the providers as well, because a lot of those measures are quality and outcomes, and it takes that provider engagement and partnership with the plan to achieve those numbers. Just a little bit more on the numbers. Not only 4-star, highest ranked plan in the state, puts us in the top quartile in the country, so the top 25%. And they also earned a 5-star rating for member experience. So like how the members rated in terms of their experience as being part of the plan. It was a 5-star rating, which is an incredible achievement.
It really is.
And we can compliment leadership too.
Well, we're laughing, but I think I said this in response to you, Eric, that it's really the leadership that creates the culture that results in these kinds of outcomes. And to Joe's point, that's the people in the room that do the work, and certainly Aaron's leadership, and not just and thank you, because I'm one of the providers, my day job, but we also get a lot of guidance and support from county care to be able to do that. So it's a nice environment, nice culture that they've created. Okay, so with that, I am, since the agenda is exhausted, I will declare the meeting adjourned. Thank you. Have a beautiful weekend. Enjoy the weather. Thank you.